Hi, my name is Zachary Chandler, and I'll be presenting a case of severe rhabdomyolysis due to Legionella pneumophila. We have a 53-year-old man who presented for evaluation of encephalopathy. He had developed fever, myalgias, and decreased urine output several days prior. He subsequently became altered with agitation and presented for evaluation. The patient had a history of hypertension, tobacco use disorder, and unspecified psychiatric disorder. His home meds included lisinopril, hydrochlorothiazide, and quetiapine. He did have a 20-pack year smoking history and smoked a pack per day. There's no alcohol or illicit substance use. Vital signs: temperature 37, heart rate 100, BP 158 over 96, respiratory rate 23, SO 89%, ambient air. The exam revealed rales throughout the bilateral chest with bibasilar crackles. The remainder of the exam was normal. Labs are displayed below and significant for leukocytosis with neutrophilic predominance, as well as a widened anti-gap metabolic acidosis with acute kidney injury and hyponatremia. He had a hypoalbuminemia with transaminitis and a CK of 17,000. Urinalysis revealed proteinuria with a PC ratio of 0.49, 44 white cells per high-powered field, and 11 erythrocytes per high-powered field. Initial plain films are displayed to the right and were significant for airspace opacities throughout the left mid-upper lung zone and right lower lung zones. CT chest was subsequently performed and revealed bilateral opacities of all lobes with consolidation air bronchograms. Renal ultrasound was normal. The initial clinical impression was AKI due to rhabdo. His oliguria continued to worsen and required renal replacement therapy. His respiratory status worsened despite volume removal, and he ultimately required intubation. He was started on broad-spectrum antibiotics, and his status continued to worsen, ultimately requiring vasopressors. His leukocytosis continued to evolve despite antibiotics, and he was diagnosed with ARDS. He was ultimately treated with methylprednisolone and azithromycin. BAL revealed 511 erythrocytes per milliliter with 278 white cells per milliliter with mostly neutrophils. The gram stain, however, was negative, as well as blood and sputum cultures. Legionella urinary antigen was checked and returned positive. He treated with a course of azithromycin and was ultimately extubated and had renal recovery. So we described an atypical case of Legionella in an immunocompetent individual who presented initially with oliguric AKI due to rhabdo. It's obviously a common cause of CAP. However, extrapulmonary disease is less common and can be more challenging to diagnose if pulmonary manifestations are absent. Has a very variable presentation with symptoms typically manifesting 2 to 14 days following exposure. Most commonly, you can have like prodromal symptoms with CNS symptoms or pulmonary, gastrointestinal, and myalgias or arthralgias. Risk factors for disease include smoking, lung transplant, glucocorticoids, and immunosuppression. It should be noted that cost present in less than half of patients. So disease can actually manifest outside the lungs. Most commonly, it's going to involve the CNS or cardiovascular system, or more commonly, the kidneys, less common, dermatologic or arthritic, as well as splenomegaly and splenic rupture. So lab abnormalities are fairly nonspecific. We can see a leukocytosis with relative lymphoma, elevated inflammatory markers, hyponatremia, hypophosphatemia, and elevated creatinine and CK, as in our patient, as well as myoglobinuria and microscopic hematuria. Interestingly, the hyponatremia is actually mediated by a mechanism independent of ADH, unlike other CAPs. So in the case of our patient, myoglobin is freely filtered at the glomerulus into the tubules, where it may cause AKI in sufficient amounts via renal vasoconstriction, cast formation, and direct toxicity to the tubular cells. The triad of Legionella pneumonia, rhabdo, and AKI is actually very rare. It's been reported about 22 times since the index cases in 1980. A few closing points. Legionella is a common cause of CAP, and pulmonary manifestations are absent half the time. Severe rhabdo absent, a history of trauma, seizures, malignant hyperthermia, NMS, or adverse medication effect requires consideration of other potential etiologies. And a diagnosis of Legionella infection should be considered any patient who has rhabdo without obvious cause by history. Legionella infection should be considered in those with CAP and severe sepsis or septic shock who do not respond to empiric coverage. And we should have a high index of suspicion for Legionella infection in those with a triad of pneumonia, AKI, and rhabdo. Thank you.